So, and if it's unrelated to trauma, there's only one thing in the chest, abdomen, and pelvis, and that's typically for, if we're looking for just urolithiasis or stone. So it's something to consider when you're looking in the belly and the chest. You're typically going to do it with contrast. So when y'all see an option for those, or when you're ordering them in the future, typically CTs are with contrast. Unless you're doing for like head trauma or C-spine trauma, then certainly those would be non-colors. Those are the only 3 times I can think of off the top of my head. And we won't get into nuances of whether you should order the stone protocol without contrast or not, because you have to assure yourself there's nothing else going on in the belly that doesn't require contrast before you do that. So you're kind of limited in your study there, but just something to think about when we order those studies. So the CT is really great looking at bone. So maybe like orthopedic surgeons might use it for other things, but for most of the time, typically, unless it's the head trauma or you're worried about C-spine trauma for an accident or some sort of fall, you typically, everything else you're going to order with contrast, especially in the chest, abdomen, and pelvis. So I just want to throw that out there. All right, so today we're going to talk about vascular surgery. So we'll cover the anatomy and then all of the presentations, diagnosis and treatment. So these always like raise my pucker factor because a lot of these are, like for the ruptured aneurysms and most of these conditions, it's usually a very bad outcome if we don't catch it. A lot of the patients die before they even make it to the hospital for these. So these are important things to consider, and it's definitely more concerning when we see these. So we'll start with the anatomy here, and really the takeaway is we got 3 layers to our vessel or arterial wall or artery. So we've got our intima, our media, and our adventitia. And the adventitia is probably, for the structural integrity, is the most important part of the artery, and it's what we base our cardiovascular interventions on. So if we have any sort of insult on that, then we tend to have pretty bad sequela. So, and then typically we divide it into like occlusive versus aneurysmal disease for the arteries. And we'll talk about all of those shortly, but obstruction usually leads to ischemia, necrosis, and then aneurysm leads to rupture and hemorrhage. So neither of them are ideal, and we'll talk about the conditions we see them in most frequently. So arterial aneurysm, and what we're mostly talking about going to be your aorta, but I mean we could also see it in some other conditions as well, which we'll cover. But this is just basically dilation of whatever that artery is over 50% of its normal diameter. So we tend to see them more frequently in certain areas. However, most of them, are bad, and we'll talk about the different types. But a true aneurysm involves all 3 layers, whereas we have a false aneurysm, which won't involve all 3 layers. And the most common cause is typically atherosclerosis and hypertension. And then the AAA is the most common of the true aneurysms, and we'll get into the details and how we diagnose that and what they may or may not present like. But we tend to classify them into basically the shape of that aneurysm that we have. And some of them are worse than others. So we tend to separate them into the saccular, which is just an outpouching, or like it says, this little sac that outpouches the vessel. Fusiform is kind of a diffuse outpouching, and then we have mycotic aneurysms, which we typically associate with infection. We say mycotic, but it's typically not fungal infections anymore. But that's just how we categorize those. So the name is kind of tricky. And then we have pseudoaneurysms, which are incomplete transections. So this is typically from some sort of, like, it could be from puncture, laceration, it could be from some sort of trauma. And the problem is if there's any rupture of those pseudoaneurysms, then we can have, and the regular aneurysms too, or the true aneurysms, we can have pretty significant outcomes, which we'll talk about. And then mycotic aneurysms, it used, we say because it's fungus, but typically now it's mostly staph is what we find in those mycotic aneurysms. And typically, like IV drug users, you'll commonly see those, or somebody who had some recent infection, you can see with the endocarditis, which is typically an IV drug user as well. All right, so abdominal aortic aneurysm. So typically elderly, more common in males. And then there's numerous mechanisms here. Genetic factors play a big role. Smoking plays a huge role. So, I mean, typically, like when I'm talking to a patient, like some of the history I want to know, obviously, are they smokers? I also want to know, like, if they had any family history of any abdominal aortic aneurysm, because that plays a big factor as well. And it does have genetic factors. So it is an important history question. For family history, yes, in the ER, we don't ask a lot of family history. So those are the few times I do. Is with if I'm concerned for a AAA, I want to know if they have any family history of it, if they're a smoker. But the problem is, you know, we can't predict which ones of these have a higher risk of rupturing. So it's really hard, and we tend to categorize them as asymptomatic versus symptomatic, and then we monitor their size over time. Typically, it takes, you know, at least 5 centimeters for that to be palpable as a pulsatile abdominal mass on exam. And then if they have any tenderness with that, then we have to be concerned that it might be ruptured, which creates, you know, significant diagnostic considerations for them. Typically, they'll present unstable. We'll talk about that in a sec. So the signs and symptoms, typically that flank pain, back pain, abdominal pain, tenderness to palpation. They will have Gray Turner's sign. They'll usually have some hypotension. They may have a decreased femoral pulse. However, none of these rule it out. Even with some of the dramatic presentations, we tend to get this diagnosis wrong. So a lot of times we miss the aneurysms, like in urolithiasis patients, people with flank pain. A lot of times a common misdiagnosis is a AAA. So we always have to consider it in those like flank pain patients and our belly pains as well. We always want to consider an abdominal aortic aneurysm, because if we miss it, it can lead to devastating outcomes in these patients. So it's always something we need to consider. All right. Well, we just talked about it. Which one of the findings is most likely found? Yeah. Numero uno. All right, how do we diagnose this? Plain films, not great for these. So they're usually seen incidentally if we get a plain film and notice it on there, but the most appropriate initial test, and we can do it easy at the bedside, is just a point of care ultrasound, or we can send it for a formal ultrasound. But this is going to be our initial test of choice. And then this is what we're going to use to monitor them throughout time, as we're going to talk about some of the details of when we need to operate on them and when we don't. But this is what we usually, they get an ultrasound every 6 to 12 months, and we monitor for any expansion or size changes. The gold standard test is the CT angiography. So that's going to be your CT with an angiogram, and that's just going to better identify the size and extent of the aorta. And then the old one, the aortogram, we don't really use that anymore. That's a conventional X-ray, and we just add contrast to it. So with, you know, CTs being super common now, we don't really use that, if at all, anymore. And then obviously, because of the contrast load, you got to worry about nephrotoxicity. We won't get into a debate whether that's real or not, but there's debate. All right. So when do we want, you know, when do we want to treat these patients? So they have an increased risk of rupture, anything over 5 centimeters. Typically, we want to schedule them for some sort of operation. If it's over 5.5 centimeters, we're going to monitor them every 6 to 12 months. So if we see an expansion greater than 0.5 centimeter in 6 months or 1 centimeter over a year, then we want to operate on them. And then, you know, females have a higher risk of rupture than males. And then saccular greater than fusiform, and then smokers, you know, hypertensive, you know, anybody who has hypertension, COPD, steroid use, family history also might increase our concern for rupture. So we repair them, and it, like I said, any of them over 5.5 centimeters, but if they're asymptomatic, we send them for an elective surgery. So it's, you know, it can be done on a more routine basis. Anybody who's symptomatic needs an emergent repair right now, just because they have a greater risk of rupture, and if it does, the mortality is pretty high. So anybody symptomatic, they need to get surgery, and then any rapid expansion over 1 centimeter in a year needs to, they're a surgical candidate as well, so we'll schedule them. And then here's a couple, you know, we can do an open procedure, but typically now we do an endovascular aneurysm repair. So we go into the femoral arteries with a catheter, and then we just float a stent in there, and then we stent that area. Typically, they'll run some more intraoperative studies so that with contrast to evaluate the repair, but this has become the common practice now is the endovascular repair for these aneurysms. All right, so 4 hours following aorto bifemoral bypass, 68-year-old, total urine output of 30 mils. Is that normal? Yeah, no. Obviously, should have like 0.5, mils per kg. So which of the following is the best next step in management? Yeah. Bolus fluids, everybody agree? Who says start furosemide? Yeah, I was hoping you do that. All right. And if we were doing a CT angiography, I don't even know how you would do it without contrast, actually, now that I think about it. So obviously, if you are CT angio or an impulse contrast, I don't think it's an option order without contrast, but it's a great distractor for people not paying attention. All right, so what are the complications we can have? So like, we talked about, infections, we can get a mitotic aneurysm. I'm thinking of a fistula, which can be concerning. So that's something we have to consider, any communication with their structure. So sometimes, you'll see a patient that might have a AAA, and they start to have signs of like heart failure. So that should raise our suspicion that they may have some sort of fistula or communication with another structure. And commonly the AAA can have a communication with the IVC, and it leads to a high output heart failure. So that's something to consider, especially in a known patient with an abdominal aortic aneurysm. And then we can have communication with the GI tract. You can get pretty significant GI bleeds as well. So we have to think about that, especially in that upper GI bleed patient when we're evaluating them. And then we have what we call blue toe syndromes. This is from basically like microemboli are getting thrown down the aorta and they're becoming lodged in one of the digital arteries. And then it turns into, you then have this cyanotic looking digit. They'll usually have pain with it. They might have it might be cold, numb, but this is something we always have to consider, especially in somebody who has any sort of embolic disease. So a sudden onset of pain and purple discoloration in the presence of palpable distal pulses should raise our suspicion a little bit more for some sort of embolization and potentially limb-threatening arterial problems. All right, you got 65-year-old asymptomatic 6-centimeter aneurysm on CT angio. What's the best option for treatment? Yeah, 2, elective abdominal aortic aneurysm surgery. All right, so what if it was, what if last year it was like 3 centimeters and this year it's 4? Are we doing surgery for that one? Yeah, and if they're asymptomatic, are we doing emergent surgery, elective? What do we think?
Elective.
Yeah, elective if they're asymptomatic. Good. All right, let's talk about thoracic aortic aneurysms. So these are pretty devastating. Typically, these patients don't make it to the hospital, and we'll go over some percentages here shortly, especially when it involves a trauma patient. But there are, some different causes that we've identified with them. So obviously, if they have any sort of history of a dissection already, that's concerning. We also see this in our connective tissue disorders or Marfan's. My last unit, we had a dude. He was like a 36-year-old. He had a thoracic aortic aneurysm. He didn't know it, and it dissected, and he almost died. Luckily, they caught it. And they were able to repair it and save him. But it turned out he ended up having Marfan syndrome, which didn't look like all the pictures they tell us. It's like this tall, skinny dude with, what was it, the arachnodactyly and all these other findings. It didn't look nothing like that. But he ended up having Marfan syndrome when they did the genetic testing. So that was an interesting case. Obviously, he had to get airlifted to a vascular surgeon. It was a big deal when that happened. But we definitely weren't expecting it. He just complained of chest pain, which we'll talk about the symptoms here shortly. he just complained of that like ripping, tearing chest pain, and then luckily somebody called an ambulance in the air, but you know, the paramedics were like, oh crap, and he was hypertensive, so luckily they called the chopper and airlifted him. But all right, we'll start with aortic transection. So this one, commonly seen with trauma, most of them don't make it off the scene, like 80% die at the scene. The ones that do still usually have a poor outcome, depending on their condition. What's important is that we consider it and we catch this. So, you know, we see auto crashes, especially if they're only wearing a lap belt, or if they're not wearing a seat belt, you can have that deceleration injury into the steering wheel. But it can also be, you know, they can also be restraining. You can see this motorcycle crashes, you know, fall from heights. It's normally distal to the subclavian artery. And if they survive and the adventitia holds, you know, you'll see that wide mediastinum on chest x-ray. You know, you can also see it on an angiogram as well. But, you know, this is something we need to catch early and treat early. Typically, they'll need, you know, immediate surgical repair of this. So, our best test for the thoracic aortic aneurysm is going to be our CT angiography. So, this is the most reliable test. And then we tend to grade it into what sort of, like how deep the injury is, whether or not it's an inspal injury, intramural, versus pseudoaneurysm versus a complete rupture of the aorta. So typically, if they get to the hospital, we can sometimes delay the repair long enough to get imaging. The important consideration is we have like really tight BP control, which we usually don't like to do with anything else. This one typically, like heart rate under 60 and a blood pressure under 120, we try to keep it around 100 here. Typically we use esmolol a lot. That's like the best beta blocker we use. And that's because it has the shortest half-life, it's fast on, fast off, and we can provide really tight blood pressure control within a narrow range when we use that. But the initial management is obviously, yeah, we want to get those beta blockers on board, decrease shear on that vessel wall, and then we can plan for surgery, and then get our, you know, imaging to look at the extent and what sort of operation they're going to need. And typically you can do open versus an endovascular repair with a graft. So there, yeah, so we're talking about dissection and transection. I know the terms can be confusing. Dissection is basically a tear in the wall, and then so you have a leakage of fluid, typically, you know, somewhere in the media, and, you know, it can create a very large lesion depending on where it's located at and how significant it is, which is what's concerning. A transection is a complete laceration of all three layers. So typically with trauma, we're worried about a transection. So there are some other, you know, things that we can look at, like whether, you know, whether we think they have a brittle aortic wall. How do you determine that? Who knows, right? It's typically we associate, okay, they're probably elderly, they probably have multiple comorbidities. So these are, you know, great terms we use in the textbook, but it's really hard to identify that and who that patient is. But, you know, we typically think like some sort of destruction of the arterial media, loss of elastic fibers, and then intima tears, and then blood leaks into the wall. All right, so for our aortic, the thoracic aortic dissection, we have, you know, a couple classifications we use. Why use one when you can use two? That's how I look at it. I know you guys don't enjoy that, but all right, so we have our DeBakey and our Stanford classifications, and really they just classify it on where the location is in the aorta. Typically the ascending aorta is seen more frequently and they're more concerning, and that's just because we have mechanical forces are a lot higher that close to the left ventricular outflow tract, and so you tend to have a more significant presentation or higher risk of rupture. So those ones, I mean, all of them are going to be managed with surgery, but those ones typically present a lot more acutely and something that needs to be repaired immediately, whereas like your Stanford B may not have to get an emergent repair, and they have a little bit more time for operative planning with those ones. All right, so how do they look like when they present? Typically, like we said, you know, men, oftentimes you see it more commonly, typically in the elderly, they'll complain of that sharp tearing back, you know, chest pain that radiates to the back. Typically have a history of hypertension. You should be more concerned if they, you know, are more suspicious if they had a prior cardiac surgery. But, you know, you can also see it look like, you know, are people still doing cocaine like they used to? It used to be a big deal, you know. used to have people on cocaine a lot. You might see the weightlifters. I think cocaine's fallen out of favor. We won't get into that though. And then family history is a big consideration as well. So what you might see is like a pulse difference between the two arms. You may see a blood pressure difference in between the two extremities. And you can hear a diastolic murmur. They may have pulmonary edema. If there's carotid involvement, you may show signs of the CVA. So these are all considerations we have to think about when we're evaluating these patients. All right, so what do we do? Well, first we need to make sure it's not they're not having an MI or a PE. So this is why we consider a dissection, an MI, PE. When anybody comes in with chest pain, we need to consider all of these. So this is a pretty big job we have to do. So some of the, the initial test, obviously we get an EKG, and then a chest x-ray is the quickest and easiest initial test we can do. And if we see that widening in the mediastinum, that raises our suspicion a little bit more that it could be an aortic dissection. Now, the CT is going to be our gold standard imaging for it. However, once our suspicion is high enough and we see it on CT, we'll a lot of times have to get a transesophageal echo. And that's just going to look if there's any involvement, ascending aorta, and then we're looking for that intimal flap. So that can be a sign that they have a dissection of the thoracic aorta. And then, like it says, these three findings were very common in patients who had a thoracic aortic dissection. So they got that abrupt onset tearing, ripping chest pain to their back and abdomen. They got a pulse deficit. And typically you'll see it especially lower extremity versus upper extremities when you more commonly see this pulse deficit. And then the wide mediastinum on chest x-ray. So if you have a suspicion for this, then obviously we don't get a blood pressure, and sometimes we may not check a pulse in the lower extremities. We should be. So you need to think about this when you're evaluating these patients. All right. So what are we looking for on the TEE when we're diagnosing these patients? Yep, an intimal flap. Good. And everybody knows what a TEE is, right? You got to stick the ultrasound probe into the esophagus, down the throat. Yeah. So it's a little, it typically requires some sedation. It's a little bit more invasive. All right. So yeah, untreated mortality 75%. Treated, the mortality decreases. Still pretty high though. So 27%, still a pretty large number. Like I said earlier, we need to get initial blood pressure control. We aggressively manage it. So typically heart rate 60 or less, and then their blood pressure, we want to keep it right around 100, under 120 for these patients. And like I said, esmolol is usually the easiest, and we can titrate it and then get decent rate control with it. And then if we have concerns with overcorrection or any side effects, we can easily turn it off as well. Sometimes we might add a vasodilator to it, like nitroprusside, but we typically want to do that after we've used our beta blocker options with our esmolol. And then emergent surgical management for those ascending ones like I talked about, so that's typically your Stanford A. And then the descending aortic dissections, we can usually medically manage them versus surgical, but acutely we typically don't need to take them urgently to surgery. So the descending is a little bit better outcome. All right, so we got a 65-year-old complaining of acute onset of pain in the anterior chest. It's excruciating, radiates to the scapula. What else radiates to the scapula right there? Talking about last time, like pancreatitis. So that's what's difficult, right? When you're, when you're actually practicing, is everything sounds the same, and patients are sometimes, not the best historians on explaining their pain as well. The respiratory rate, so tachypneic, tachycardic, hypotense. So is this stable, unstable? Yeah, definitely unstable. Then you hear a diastolic decrescendo murmur in the right sternal border. What are we thinking here? Yeah, likely dissection. Good. All right, mesenteric ischemia. So This is typically going to be like some sort of atherosclerotic occlusion of the mesenteric vessel. This is a difficult diagnosis as well, and it's something we always have to consider in abdominal pain. And these are typically going to be in our elderly patients, and they'll usually have severe to diffuse abdominal pain. And when we say pain under proportion, I don't know if I said it before, it's something once you see it on exam, you should remember it forever, because you basically have this benign exam. So the abdomen is usually going to be soft, not very tender, but that patient is going to be in excruciating pain, and it's going to kind of raise your spidey senses, say, something isn't right here. This patient should not be in this much pain. And then it can help lead you in your diagnosis, but it is something we always have to think about. And this one's a little bit more difficult for diagnosis because everybody that comes in acutely, we typically get just a CT, a contrast CT, abdomen and pelvis. This one requires CT angiography, so you have to be thinking about this diagnosis in that patient, because they're going to require a different study for it. It's a little bit more difficult to diagnose, and because it doesn't present typically like it. The patient, you may not think about it if it's a benign exam, he's just a little bit whiny, which is not the best way to approach these patients. And just to make it more complicated, we also have a chronic mesenteric ischemia. So these patients will have like a, food fear, they'll have increase in pain after meals. So they'll typically present, they'll have some weight loss, they might, look cachectic or malnourished. And they typically complain of diarrhea, nausea, vomiting. We might have hematochezia. And then this one we can do, there's angioplasty and stenting that we can do for revascularization option. All right, and then we have colonic ischemia, which is just hypoperfusion. So you might see this in a patient that presents, they're dehydrated, they might have had some sort of recent gastrointestinal infection. Anything that can cause dehydration, basically we have hypovolemia leading to a decrease in perfusion in that watershed area, typically between your superior and inferior mesenteric artery, is the most vulnerable. So this might, they might be complaining of pain, and this is, we can see this on imaging as well. The good news is we typically don't have, this will typically resolve on its own. They may complain of some hematochezia, diarrhea, abdominal pain, fever, but CT is going to be, another great test for this. We typically don't get abdominal x-rays. And then we have to be careful with endoscopy, just because any sort of like overdistension or pressure on the colon can worsen it. So we typically don't do a colonoscopy in these patients. And most of it is just supportive care, so IV fluids, bowel rest, antibiotics. If we find an infarction, then that does require surgical treatment. All right, did you guys cover strokes yet? Yeah, so we're going to talk about some cerebrovascular disease. We're going to stick more to the carotid though, and carotid artery disease, which is about a fifth of the stroke patients have some sort of carotid disease causing their symptoms. So, many are asymptomatic. We have to be concerned with this, especially in our TIA patients. So typically this is some sort of stroke symptoms that spontaneously resolve. They have this time on there within 24 hours. That's just like a line in the sand. There's no real reason, or there's no physiologic reason we say it, that we came up with that. But by convention, we do 24 hours as the limit, and if they improve. But typically they'll have some sort of hemiparesis, slurred speech, your typical stroke symptoms. They might have like amaurosis fugax, which is just an embolism of the ophthalmic artery, and that causes temporary monocular vision loss, which can become permanent. So these may be the first symptoms of carotid artery disease. This is why we need to consider this when we're working on those stroke patients. So typically that's why if we suspect some sort of cerebrovascular accident, a lot of times we'll get a CT of the head, non-con, which doesn't work real well. It only looks for a bleed. So this typically is not caused from a bleed. It's typically from some sort of embolism. So a lot of times we'll get a CT angiogram of the head and neck just to evaluate this further in all of our stroke patients. So it's always something to consider. especially depending on what symptomatology they have and how we're classifying this. And then on the picture there, you got that what's called the Hollenhorst plaque on there. So just, you got that bright fleck on there and arterial bifurcation of the retina, maybe a sign you see on your retinal exam. I don't think I've ever gotten a retinal exam that looked as good as that picture, but I'm working on it. And then they may have a bruit, but it's non-specific. You know, you may or may not hear a bruit. You may hear this. They may have a stroke and hear a bruit, and it has nothing to do with this. So it's up, but it is something that, you know, we always want to evaluate for when on these patients. All right. You got a 65-year-old. He's got everything: hypertension, diabetes, had an MI, profound weakness in his left arm. And when you look at his retina, you see the Hollenhorst plaque. So, what do you think? Yeah. I think I'm gonna have to rewrite these questions to make them a little better. It's too basic. All right. So, what do we do for these patients? So this one, what would be the next, like the first study, what are we finding ultrasound in this patient in the neck? However, when they present like that, we'll typically have gotten a CT of the head and the CT angio, but the ultrasound is going to be a great study, and we'll talk about it in a second. Typically, carotid artery disease is typically from some sort of atherosclerosis and some embolization, as you see on the picture there. So that's how our atherosclerosis forms in our vessels. And then we have some sort of damage to that plaque. Like in this picture, there's an ulcer, and then it causes platelet deposition to repair that. And then that platelet emboli are what ends up in the carotid artery tract, or as it goes into the brain, and that's why you have those symptoms. So it's typically some sort of embolization getting thrown into the vasculature in the brain, causing your stroke symptoms. And then we also consider it from AFib as well, which AFib is the most common arrhythmia, and we see it a lot, and patients a lot of times are asymptomatic, don't know they have it, so that predisposes them to emboli, and that's definitely another cause that we may see CVA. And then they can, you can also have narrow artery, decreased perfusion, certainly another cause for brain ischemia. All right, so what's our most, what sort of testing do we do for this? So like I said, so duplex ultrasound, most useful test, non-invasive. We don't have to send a bunch of contrast or anything, and it can give us an evaluation if there's any sort of disease there. CT angio is typically our preferred image, like our preferred advanced imaging study on it. Now, if you're at a stroke center, they might have MRI. We're not going to talk about that. I mean, that's certainly, if they're a stroke center of excellence, they may have MRIs emergently in the ED that they can do at those centers, just because they have the neurosurgeons there to operate on these. But most places are still a CT angio. The initial test is our duplex ultrasound. And then obviously it says an echo. We want to rule out that they don't have AFib, that it's not an emboli from the heart or the atrium going there. And then any valvular disease, recent MI. The gold standard is, cerebral arteriography, and that's usually only if we're planning surgery. All right. So once again, smoking is like implicating a lot of these, and atherosclerosis. So what do we do for medical treatment? And this is commonly seen in asymptomatic patients, because it typically takes like over 50% for them to become symptomatic. So a lot of times it's incidentally seen. I think I saw one a few weeks ago, and they had like 50, it was like right at 50%, unrelated to their symptoms, but they came in for a syncopal episode, and we'd scan them. So it is something, a lot of patients will be asymptomatic. So if that's the case, and we're medically managing them, we need to, get them, they need some sort of smoking cessation, and we need to counsel them appropriately. We'll typically give them a daily baby aspirin. Clopidogrel, we don't typically initiate that if we're planning on surgery, but we can, as long as we're not planning on surgery. And then obviously serial duplex scans, so we'll scan them a few times a year just to check for any sort of further occlusion of that vessel. And then surgical management is a carotid endarterectomy, so open the artery, remove the plaque. And this is typically they'll have over 50% stenosis. Typically they'll be symptomatic at that point. You can stent them in younger patients, but it is associated with a higher rate of emboli. So we do have the dual antiplatelet coagulation afterwards, or we call it dual antiplatelet therapy, so we usually get aspirin and clopidogrel. Not too fast. All right, so 59-year-old, moderate hypertension and emphysema. Presents with a TIA. Ultrasound reveals 75% narrowing. What's the most appropriate treatment recommendation? Yeah, I mean, 75%, he'll need angioplasty of the carotid lesion. Just how large it is, and it's likely going to be symptomatic. It's having TIA, so it is. So he's going to need some sort of emergent therapy for that.
So, with the duplex scanning for following the patients with carotid artery disease, I'm sorry, is that like a CT or is that a form of a?
It's an ultrasound. So when we say duplex ultrasound, what we mean is we're looking at the color flow in the basically a Doppler, so it looks at the artery and the flow through it, and that's typically what we call a duplex ultrasound when it evaluates the artery and the flow. And with the ultrasound, if it's facing away from you, it's blue. If the vessel's coming towards you, it's red. So it's just a useful test we can use at the bedside. I don't remember which EMED block is all ultrasound scanning, so you guys will learn all about that, all about your friend's anatomy when you guys do that. But it's very simple and easy. Just click a button on there and you can evaluate that. All right, peripheral vascular disease. These are our claudication patients. Typically, some hyperlipidemic state it's associated with, and most commonly we have our femoral arteries involved, our iliac arteries, and we'll talk about that and where the location is. But predominantly a disease of the lower extremities. We typically don't see in the upper extremity. If we do, it might, typically it's confined to subclavian arteries. So we typically don't consider this except for lower extremity. And like I said, so superficial femoral and iliac arteries are the most common locations you can have this at. And then it increases with age, so like, a fifth of the patients over 70 having it just increases as we age. Obviously, everything, I feel like everything is worse with diabetes. So obviously comorbidities play a role as well. And typically, this isn't significant enough where it's going to need an amputation, it's going to present gangrenous. This is typically going to be a patient that complains of just intermittent pain in lower extremities, worse with exercise and certain activities, and it's usually relieved with rest. All right. Subclavian steel. This is a fun one. So this is basically a condition where the subclavian artery, like occlusion of the subclavian artery, causes a retrograde flow into the vertebral artery, and it causes symptoms of brain ischemia. So this is going to be typically associated with the left upper extremity more commonly, and this is going to be with any sort of activity with that extremity. It's going to cause ischemic symptoms in the brain. So they usually present with like an arm pain, they may be lightheaded, they may have stroke CVA type symptoms, but on imaging and our evaluation, we will, we can identify that it's subclavian steel syndrome, and hopefully we can fix it. This is usually like Typically, like a younger patient, they'll have some sort of overhead activities, and then they'll complain of like left-sided pain. They might have numbness in their upper extremity, tingling, those sorts of symptoms. But it's usually atherosclerotic occlusion of the subclavian artery. And then treatment, we have endovascular and surgical repairs for it. We won't get into the different details of those surgeries, but they'll typically require a surgery. All right, so what do these patients present with? So they'll have that intermittent claudication, so it's going to be pain from ischemia, but typically they'll complain with it with activity. They'll say it. And usually they're elderly, so they'll say, I was on my daily walk today, and every time I hit 1 mile, I tend to get this really significant pain in, my left leg. And then it gets better once once I've stopped exercising, it'll typically improve. And then we do have, depending on where the stricture is, it can be correlated with different symptoms. So like calf pains, typically from the femoral artery. If they have like buttock or thigh pain, and it's, iliac disease is more common. And then if they have like impotence, then it can be a little bit higher, and it can be hypogastric. So most patients are asymptomatic with up to 40% of occlusion. So it takes a little bit more than that for them to start to have symptoms. If they have any pain at night, like rest pain while they're not exercising, that's usually an important consideration that this could be limb threatening. So that is something we need to consider. You can also, patients will also say they might hang their leg over the edge to decrease the pain. They might sleep in a chair. I had a patient over the weekend who was sleeping in a chair, not for this, but I was like, oh, that's interesting. So it's always something to think about when you're talking to the patient, they're explaining everything to you. All right, so what are we going to see on our exam? So we might have like decreased or absent pedal pulses. You might hear a bruit. A lot of times, the more common things we see are like you'll see decreased hair, a shiny brittle area. They may have muscle atrophy depending on how long it's been occurring for. These may be patients you see that have like an increase in lower extremity ulcers or healing in wounds. You'll see this in the diabetic patients. They typically have, comorbid diabetes with this. So you'll tend to see a lot of ulcers and other indications that this may be one of the causes. If they elevate it, you might see pallor, and then dependent rubor, which is, it's red when the foot is hanging off the bed. Then, like I said, they could have ulcerations. But how do we test for this? So we get a simple bedside test called the ankle brachial index. Have you guys heard that?
Yes.
Basically just, blood pressure of the upper extremity versus the lower extremity, and then we do some math, which we'll do in a second. And then anything under 1 is usually concerning that they might have some sort of claudication or some sort of atherosclerotic disease, that vessel. Here's our ABI. So typically you'll need some sort of Doppler to listen for the sound. Typically your stethoscope's not going to work like you would in a normal blood pressure, so you'll have to get a little Doppler so you can hear it. And then you just get the systolic pressure of the upper extremity, and then you divide it by you take the lower extremity and divide it by the upper extremity. And anything less than 1 is considered positive. All right, so diagnosing this is typically with our ABI. So obviously history, physical exam, they have the right symptoms. We need to be concerned for it, and then something simple at the bedside we can get is just the ABI. Sometimes you will have to tell your nursing staff how to do it if they've never gotten one, or you'll have to do it yourself. It's always important to know if you have a Doppler machine in your clinic to start with, so it's always something you need to check your work environment for. They're small and people like to steal them is the problem, so that's why they end up missing. We always lose ours in the ER, so we have this giant one now. It's like the size of like a shoebox, which is completely like outrageous. You don't need that. They're typically little pocket machines, but they simply have that because it's not easy to steal, which I know sounds bad, but so a lot of times you gotta look around, make sure you can find it. If we're doing any imaging, typically the duplex ultrasound is going to be our best test for this. If we're worried about or we need to have any surgical management, then we'll get the CT angiogram. It's going to be our typical CT. We order imaging study to help. Obviously, management, they need to stop smoking. That's going to be the single most important risk factor. So, obviously, smoking cessation, and then we need to make sure their comorbidities are under control. So, we control their hypertension, their diabetes, their hyperlipidemia. Exercise is important for this one, which is going to be hard, right? If they have pain with exercise, how are you going to convince them to exercise? So, it is why we need to control all of these other factors. We can get them exercising again and improve their symptoms. And then we do have medications we can use. So we can do like our, statins, our antiplatelets like aspirin, clopidogrel. We also have our cilostazol and pentoxifylline. So those are other ones that can help. And they're typically more of like we kind of work our way up in treatment for these patients. So we start with, lifestyle, smoking cessation, exercise. And then we look at other interventions we can do for these patients with these medications. Take a 10-minute break. All right, so what are our treatments? What are our operative interventions for peripheral vascular disease? So we can do endovascular repair, so we can put a stent in there. We can do percutaneous angioplasty. And then if there's limb-threatening disease, we can do like a bypass and grafting for it. But the overall goals are just quality of life. Typically it's in the elderly. So we obviously want to prevent limb loss. We want to maintain bipedal gait. So we want to improve their quality of life and avoid disability. Amputations are rare. So like 5% of the patients, typically, and that's typically 5 to 10 years after they're presenting with claudication. So it's not as common as you might think. All right. 71-year-old female. She's got lifestyle limiting claudication, undergoes angiography, imaging shows heavy disease burden, the aortoiliac region. She undergoes aortal bifemoral bypass. Before the closure of the skin, which of the following is the most important next step in managing this patient? It makes sense, right? We probably want to make sure we fix the problem, and we want to assess peripheral pulses that they are still present. So, pretty basic question. Obviously, if it's not palpable, we can use our Doppler to help us with our examination, which, if anybody's confused on Doppler, that's basically you place a probe on there and it makes a noise for you. It's a speaker, and it's just a little bit better than like what you would get with a stethoscope. And then you can manage to find smaller vessels with it as well. So that's an option we like to use if we can. All right, and let's talk about acute arterial occlusion. So this is most commonly from emboli. It can be from chronic peripheral vascular disease, and obviously trauma, which is probably the most common cause. So this is where we're going to have our 6 Ps. So our pain, pallor, poikilothermia, paresthesia, pulseless, paralysis, and it typically presents, that's kind of worsening order there with those symptoms that we have. However, any one of them can be present, but this is when some sort of complete occlusion of that vessel causes this increase in severe pain in these patients, and they can have a pretty high mortality and morbidity associated with it. But typically, the only manifestation a lot of them present with is just pain. So it is something we need to consider, especially in the right patient. So if we have these peripheral vascular disease patients and they're complaining of increased pain, we need to think about this. We also need to think about if they have any of those comorbidities, like they have FEB, they have the coronary artery disease. This is something we need to consider because those emboli can be occluding one of these vessels, and this could be limb-threatening, so it is an emergency. All right, so obviously we have to have a suspicion, so we're going to have our, some of our P's on there, typically starting with pain, and then we have to have a suspicion for it. So have you guys heard of hard signs for like vascular injuries? Have we talked about that yet? Or are you talking about any of your other classes? So typically with any sort of vascular trauma, we tend to base our acuity on how emergent we need to treat this on what we call hard signs, which are any severe bleeding. If we have an expanding or a pulsatile hematoma, absent or diminished pulses, and then a thrill or a bruit are what we call our hard signs. And we'll talk about that more in our trauma lectures, especially in like neck trauma or cervical trauma and some of that vasculature there, but it's important to remember what the hard signs are. And obviously, our goal here for treatment is going to be reperfusion of that limb. So we may have to start with anticoagulation, like with heparin initially, and especially in our atraumatic patients that we're not worried about bleeding from anywhere else. And then we can get our further imaging studies, like an arteriogram. We can also get a CT angiogram as well. And then we do have different treatments, so depending on if it's embolic, we can look at like thrombolytics, like if you guys remember one that we use for stroke, like TPA is one. Or an embolectomy, which is a lot more common nowadays, especially with more of our advanced imaging procedures that we can use. And then if there's any trauma, then we need to worry about other considerations like any sort of compartment syndrome, so we'll need to get compartment pressures, and then we'll look at doing a repair based on what sort of extent and damage that they have to those vessels. All right, arterial stretch injuries. So this is one that's more commonly seen when we have some sort of like anterior knee dislocation, and we're not talking about patellar dislocation, we're talking about actual knee dislocation, which does happen. So, we used to associate a lot more with like what we call the dashboard injury. So basically you have a car accident, you're sitting, and your tibia basically receives the trauma, your femur stays in place. And so that's where we most commonly see the dislocation. We can see it from all sorts of sports injuries, and we also worry about it with any sort of penetrating trauma as well. But the tricky part about this is a lot of those patients will, not a lot, some of them will have the knee or whatever dislocation is will have reduced on its own before they get there, and so we still have to have a suspicion here. I've definitely had plenty of soldiers tell me their knee completely dislocated and it looked like that. So what do you do with that one, right? You obviously have to evaluate. An ABI is a great test if it's non-emergent. Obviously, if it's emergent, we may have to look at reducing that knee immediately, but we need to check for any, distal perfusion. And then we need to assess how long ago the injury was, because it's important that we repair these. Typically within 6 hours is kind of the rough guideline we use, but all of these are going to be urgently managed. All right. So obviously any sort of transection in the artery typically associated with trauma is going to be another concern that we have. And sometimes we may see that transection with some sort of bone fracture as well that's causing the transection, which is why it's always important that we get our distal extremity pulses. And as you can see with that arteriogram there, they have that fracture and it's completely transected that artery. So they're going to need to go, they're going to need a vascular surgeon to help repair that and restore perfusion to that lower extremity. And like I said, it's got to be corrected quickly, so this is emergent. All right. So, like I said with the hard signs, if there's no hard signs and they're hemodynamically stable and we don't have a fracture, we can obs them. So, and that's typically, we got to get that ABI. So, we like to have a normal ABI or over 1. And then if that criteria is met, then we get our CT angio imaging, we make an arteriogram or duplex ultrasound. Typically, if we're worried about these penetrating injuries, we start with that CT angiogram, as long as we don't have any of those hard signs and we don't see a fracture there. If they have hard signs or obvious signs of vascular injury, then we take them straight to the operating room for exploration. All right, popliteal artery entrapment. So this is going to be a younger patient, and typically it's like they were born with this or congenital abnormality or anomaly. where the medial head of the gastroc compresses or displaces the popliteal artery. They typically will have intermittent claudication, asymptomatic at rest, and they'll usually be in a younger patient. They'll complain of, pain with running or any sort of long or prolonged exercise. And one of the indications that they don't have any signs of atherosclerotic disease or TAD. Then we need to consider, hey, this is a younger patient. I don't think they have any sort of atherosclerosis. Maybe this is like a popliteal artery entrapment. And typically these will be like chronic pain patients that are complaining of this. And it's something we always have to consider. So, we'll start typically with our, we can do like a duplex ultrasound. Angiography works well too. Sometimes we'll actually have to evaluate them for a compartment syndrome as well. So we'll have to get muscle pressures. But these patients are going to be the younger ones, and they will require surgery, but it's not acute surgery. So this is typically one we can schedule for an elective surgery, but it is something we need to consider in these patients that are younger, complaining these claudication symptoms. All right, Berger's disease. So this is that younger male smoker has these, has this migratory superficial phlebitis. Unfortunately, it's affecting the distal arteries, so we don't really have great options for bypass. We don't actually know what causes it. We think it's like some sort of autoimmune component, but we just consider it like a non-atherosclerotic vasculitis, typically the small and medium arteries. Smoking cessation is a large portion of our treatment for this. And these patients, unfortunately, might require multiple amputations throughout their lifetime when they get this. Yeah, that was cool. AV tissue, right? It looks like aliens in there or something. So this is communication between the artery and a vein. And this is basically the arterial pressure dilates the vein, and we see it more commonly after trauma. We see it iatrogenically from something recreated there. You especially see these a lot in our hemodialysis patients because they'll require this in order to get their hemodialysis. So most of them will have something that looks like that. Usually that's normal if they're on hemodialysis, but obviously, if we, in the right patient, if we have some sort of trauma or we suspect it, we need to consider it. So they'll typically have some sort of thrill over the anastomosis site, and we can repair these by vascular surgery. Obviously, most of the ones we see are hemodialysis related, and they need that, so it's required for their dialysis, so we don't do anything for those. But, if a patient, you had some sort of procedure, like we might see it with if we place a femoral artery catheter in them, this is something we need to consider if we, after the procedure, we then have like one of our hard signs, like we have like a pulsatile hematoma in an area where we should have been cannulating that vein, and this is something we need to consider in those patients. All right. What questions you guys have? I have some. No, nothing, nobody. All right, well, that's all I got. I'll hang around. If anybody has questions, we don't want to say in front of everybody. There's